Hi, I'm Dr. Barry Roberts, and we're here at my clinic, Roberts Chiropractic Clinic in Tulsa, Oklahoma. Our address is 4105 South Union Avenue, and our phone number is 918-446-1118. My background is I was trained at Palmer College of Chiropractic, the fountainhead of chiropractic in Davenport, Iowa, and I graduated in October of 1980 and have been in practice for 34 years now. So, today we're going to discuss B.E.S.T technique. When I got out of chiropractic college, I was exposed to B.E.S.T technique, and I would like to share some of the technique with you today because it's very effective in very difficult cases and cases where you aren't sure what to do next with a patient that's not responding. So the first thing we're going to do today is I'm going to do what's called a level 1 adjustment on this patient. And level 1 deals primarily with the sacro-cranial nervous system, or the craniosacral nervous system. And the first thing I'm going to do is I'm going to come down like all chiropractors do, and the first thing we do when the patient is on the table is we check their leg length. This is a sign of body imbalance, and you can see on this patient the right leg is definitely shorter than the left leg. Now, in traditional chiropractic, what we would do is we would bring those legs to 90 degrees, and you'll notice at 90 degrees the legs have now become even. According to the Deerfield leg test, which is an orthopedic test, this would indicate a posterior inferior ilium on the right side for this patient. Now, I'm going to just do a standard adjustment, and we're going to use the drop table. So I'm going to cock it and adjust it. And you'll notice that when I come back and we look at the leg length now, it's back to normal. And I bring the legs to 90 degrees and they're normal there. Even, that is. Now I'm going to show you something very interesting. I'm going to bring this patient up off my Sherry. Now I want you to just step off and just take a few steps here. Just walk a few steps and come on back and get back on the table. Now, we get her back on the table, bring her down. This will take a second because it's moving a little slow here today. And we come back and we look at the leg length. Well, by golly, the leg is short again. So, a manual adjustment doesn't always hold as long as we would like it to. This technique that I'm going to show you will enable the patient's adjustment to hold much longer. What we're going to do is I'm going to go to the second sacral tubercle on the side of the long leg. And notice I'm using my right middle finger. I'll explain why here in a few minutes. But I'm going to find the sacral notch on the left side of the sacrum, on the long leg side. And then I'm going to take this finger, my first finger of my left hand, tuck your chin way in for me. I'm going to palpate first. I'm going to find the most tender cervical, superior cervical, and in this case it was C1. Now I'm going to hold these 2 points until they actually start to pulsate. It'll be the same pulsation that you would feel if you were checking a person's pulse in their wrist or in their neck. And as you do this more and more, I've been doing this now for 34 years, so I've kind of learned how to feel for these pulses. But in the beginning, it'll be a little difficult for you. But as you start doing this, it'll become easier and easier. Eventually, these 2 points actually start to pulsate. They just started. And if you hold long enough, those pulsations will actually synchronize. In other words, they'll pulsate at the same rate and rhythm. That's what we're looking for. Now, I'm going to go to the second sacral tubercle, and I'm going to hold that spot, and the superior cervical, tender cervical vertebra. Again, using my middle finger. I'll explain why later. Now I'm going to the sacral notch on the right side, on the short leg side, and again with the first finger of the left hand on the tender upper cervical. Now the upper cervical could be C5, could be C4, could be C3, C2. You just have to palpate for the one that elicits the most tenderness, or the one that you know from your palpatory skills is the one that is farthest out of place. In this case, her atlas was pretty well subluxated, so it was easy to palpate. Now, did the same thing, waited for the pulsations to synchronize. Now there's one more thing I like to do when I have the patient face down and we're working on this cranial sacral portion of the nervous system. I like to go along the tensor fascia lata on the side of the long leg, and the patient's going to tell me when I hit a real tender spot. So I'm just going to go along the tensor fascia lata. You tell me when I hit it. Right there. Didn't have to go far. And I'm going to synchronize that again with the upper cervical vertebra contact. I'm going to wait for those 2 points to pulsate. Wait for them to synchronize. And then I'll continue up the tensor fascia lata.
Yes.
Boom, hit another one. You'll find that people that have problems mainly in the low back and hips will have multiple tender points along the tensor fascia lata. I believe that you should work on each and every one of these until you get them to synchronize. Another way of telling whether or not you've done a good job is just to go ahead and kind of rub that area. Does that still hurt? Not like it did. So we've done a good job on that one. We can move on up. Okay. We've gone through that. Everything seems fine. Now I'm going to come back and I'm going to do that same orthopedic test, the Deerfield side. You'll notice now, without me manually adjusting anything, the legs are again even. And at 90 degrees, they're even. Now, I'm going to bring the patient up. And sure, you just take a few steps. Come back. I could have had her walk a mile and it wouldn't have changed what you're going to see now. And the reason that we're going to get such a great result here is because, now you'll notice it stayed even this time. So manually adjusting, while I believe in it, and I do it all the time, isn't the only thing that you can do for the patient. The reason this works so well is because I'm working with the sensory portion of the nervous system. For every motor fiber, there's 1,000 sensory fibers in the nervous system. And this is a purely sensory technique. And basically what the brain is doing is evaluating this tactile or touch that I'm using, but I'm doing it at very specific areas on the body. And so the brain is forced to reevaluate what's going on there just by me touching it. But the key is getting those 2 points to pulsate and synchronize. Now we have brought the patient up from a prone position, and now we have the patient supine. Now we're going to work on different cortical centers within the brain itself. Unlike traditional chiropractic that works mainly with the spine, we are actually going to go and find interference in the brain itself. To do this, I'm going to go back, once again, look for body imbalance. You'll notice now the patient supine. I look at the leg length. Relax your legs, please. And you'll notice that this left leg in the supine position is now short. The right leg is long. Now, I'm going to show you something else about most patients, and I'm sure this one won't be any different. I'm going to check the flexors and extensors in the lower body. And to do that, I'm going to do simple muscle testing. So I'm going to keep your leg out here. I'm going to push in like this. I want you to just try to keep your leg out here for me. Okay, resist, resist, and it goes weak. And I'm going to do the same thing on this side. Resist, and it's weak. Now I'm going to check the extensors. Resist, that's weak also. Resist, and that's weak also. When I'm finished, all that will be strong again. Now, the first thing we want to do is we want to check the cerebellum. The cerebellum is a cortical center in the brain that controls coordination, fine muscle movement, and balance. That's muscular balance, chemical balance. And an easy way to check to see if the cerebellum is in fact working properly and is free of interference is to do a simple muscle test. And the muscle that we're going to use today is the deltoid. Why? Because it's easy. The patient just raises their hand. They keep their elbow in a locked position, fingers straightened together, palm facing their feet. I have her resist, resist, and it's good and strong. Unless the person has torn their deltoid muscle, it should test strong or normal. Another way of saying this is she's demonstrating normal physiological response to this test of this muscle. Now, I would just want you to turn your head to the right. She just merely turned her head to the right, resist, and the arm goes weak. Why is that? Well, when her head was in her neutral position, the cerebellum was not activated. One of the jobs of the cerebellum is to keep track of where our head is at all times in space. As soon as I took her head out of a neutral position, we activated the cerebellum. That's an easy way to test to see if the cerebellum is working properly. In this case, it wasn't. Now, the next thing I want to check on this patient is another cortical center, and it's called the thalamus. The thalamus is control of the body when our eyes are open. So when we're awake during the day, doing whatever we do, the thalamus is really in control. And it's concerned primarily with the external environment, using our senses to relay that information to the thalamus in the brain for interpretation, and then the body decides what needs to be done. We see the bus coming, we step back on the curb, we don't get hit. So, with our eyes open and our head in a neutral position, we test the deltoid. We know that the thalamus is working properly. Now I want you to just close your eyes. When she closes her eyes, the arm goes weak. When our eyes are closed, the part of the brain that's in control of the body is no longer the thalamus, but the hypothalamus. The hypothalamus has now taken over control of the body, and it's not concerned with what's going on in the external environment. It's concerned with internal environment. How's the heart doing? How's the liver doing? How are the lungs doing? Is everything communicating properly inside the systems? And we saw that it wasn't working very well. So we know there's some interference within that particular cortical center of the brain. Now, when does all healing take place? All healing takes place when we're asleep, when the hypothalamus is in control of the body. When does all repair take place? When we're asleep, when the hypothalamus is in control of the body. So even if it wouldn't matter if you had a hangnail or cancer. If you have interference within the hypothalamus, when the body goes to try to correct or repair whatever's wrong with you, and there's too much interference within that cortical center, it simply can't do its job properly. So it'd be nice if we could clear the interference from the hypothalamus so it could kick in and do its job, which is healing. Now, the next thing we're going to check on this patient is her breathing. That's controlled by another cortical center of the brain called the cerebrum. So I want you to just take a deep breath and hold it. Resist. That's good and strong. Blow it all the way out. Hold it out. Resist. Weak. So, on inhalation, she's doing fine. She's getting oxygen into the body. She's having a hard time getting carbon dioxide and waste material out of the body on exhalation. Breathing is fundamental. You remember the old thing? Reading is fundamental. Well, for doctors, breathing is fundamental. If you're not breathing, we call that death. So it is pretty important. And in this case, half of her breathing is not working properly. That's not good. Now, plus, I want you to remember this, when her head moved out of a neutral position and the cerebellum was activated, remember, it wasn't working very well either. And remember, it controlled coordination, fine muscle movement, and balance. Now, how many times a day do you think she turns her head out of a neutral position? Every time she does, the cerebellum goes haywire. Every time she exhales, the cerebrum isn't functioning normally. Every time she closes her eyes, the hypothalamus kicks in and it's not doing a good job. And the one thing we want to do in any patient is have them sleeping properly. In fact, that's the first thing I look for with a new patient. They come in on the second visit. How did you sleep last night? Until I hear they're sleeping soundly for at least 8 hours each night, I know that there's still work to be done within the hypothalamus. Now, how do we fix this? Well, real easy. We're going to go back down here and I'm going to have the patient do something for me. When I tell you to, I want you to move your feet medial to lateral twice, and then inferior, going to point your toes this way, inferior to superior twice. Now, why would I do that? The reason that I'm going to do that is because her feet are the farthest thing away from these cortical centers that we're working with in the brain. And by moving her feet medial to lateral, inferior to superior, we're sending a very specific message to these cortical centers. And we're sending it the length of the nervous system and back down again. This has kind of a clearing effect. It's like rebooting the computer, so to speak. And what we're going to do is I'm going to stress all of those major cortical centers that we've just discussed. I want you to turn your head to the right. We've just activated her cerebellum, and it's not working very well. It doesn't like being out of neutral. I want you to close your eyes. We've just activated the hypothalamus, and it isn't working well. Now I want you to take a deep breath, blow it all the way out, hold that breath out, and move your feet side to side twice, or medial to lateral twice, inferior to superior twice. Point those toes and point them towards your head. There you go. Now, I want you to bring your head back into a neutral position. Now I'm going to explain why it was important for the fingers to be certain fingers. Remember I said that the body becomes electromagnetic as we start getting older. This is just a bar magnet. You can see it's holding these metal blinds up, so it's a pretty strong bar magnet. And on one end, I've painted it red, and on the other end, it's just regular. This is the north end, this is the south end. Now, when I place the north end of the bar magnet on the patient, resist, resist, good and strong. I couldn't move that with a tow truck. But I turn it over to the south end of the magnet, resist, and it goes weak. And I'm not pushing any harder one way or the other. I don't care if it goes weak. Doesn't matter to me. Now, for you doctors out there that are just learning this technique, the right hand the palm side of the right hand will tend to carry a north pole charge, just like the north pole on that magnet. Palm side, resist, acts just like the north end of the magnet. Back side of my right hand, south, just like the south end of the magnet. Middle finger, north or positive. This finger, south. This finger, south. This finger, north. And the thumb is neutral. Now, on the left hand, it's just the opposite. The palm side of the left hand is south. Back side of the left hand is north. Middle finger is south. These two fingers are north. Little finger, south. Thumb neutral. The easy way to remember this is just like the old baseball terminology, southpaw. So that's how you can remember that. Now, what I'm going to do now is I'm actually going to work on the hemispheres of the brain themselves. And I'm going to come and at the front of the patient, and I'm going to palpate along just above the eyeball. There's an indentation here. You doctors out there know what I'm talking about, and that is usually pretty tender. Now, is that tender on you?
Yes.
Yes. And if there's no tenderness there, you're going to go out to the temple and look for the tendermost area on the templar region of the patient and find a tender spot there. But 9 times out of 10, this point just above the eye will be tender. And I'm going to use, notice, a north pole contact. And now I'm going to go back here to the occiput, and I'm going to palpate along the occiput until I hit a tender spot. And usually you'll see the patient wince just like she did. And I'm holding a south pole contact there. And we're going to get both these points to pulsate and then synchronize. That could take a minute. And once that happens, we'll know that we've got proper communication existing between the right hemisphere and left hemisphere on this patient. Now, the reason that this is so important is because there's so much information coming in from the left side of the body and crossing over right at the point where the atlas vertebra is. And since many times that atlas vertebra is out of place, which I suspect it is on this patient, it's critical that we get some of this electromagnetic interference removed from that particular point in the body. So I'm just going to hold on to these. Now they're pulsating. And they've synchronized. Now that can take from just seconds to minutes for that to occur. Now I'm going to go on the side of the long leg in the supine position to the point again of the superior most tender cervical, and it is at C1. And now I'm using a north pole contact right at C1. And now I'm going to use a contact on the skull that's in front of the coronal suture north and in back of the coronal suture with a south pole contact. So anterior to the coronal suture, a north pole contact. Posterior to this coronal suture, a south pole contact. Back here, I'm using a south pole contact because I'm on the posterior portion of the body. I'm going to wait for those points to pulsate and synchronize. And there it is. Again, this will take some practice, to learn how to recognize these pulsations coming in, and then further to be able to palpate until you're able to actually feel them synchronized. But I've been doing this, I said, for 34 years, so I've kind of developed a touch for it. Now that I've done that, we're going to go and we want to check these cortical centers again to see if they're functioning normally again. How do I do it? Same way I did it the first time. Turn your head to the right. And we've activated the cerebellum. Resist. I can't move it. So we know that we've removed the interference from the cerebellum and it's functioning much better now. In fact, it's functioning normally again. Now, is this going to last? Is it going to hold? No, it's not going to hold. It's going to hold much longer than just manually adjusting Atlas, but it's still not going to hold forever. We know that the patient is an adult. They haven't been getting adjusted their entire life. And so they've got plenty of things that are causing interference in their system, and we aren't going to correct everything in one visit. That's why you see the patient daily, sometimes 3 times a week for a while, whatever. Now, head back in the center, close your eyes, let's check the hypothalamus. Resist. It's working normally again. Now let's have you take in a deep breath and blow it all the way out. And resist. And that's working normally now. Now we go back down. I want to check the leg length to make sure that's back to normal. And it is. We have absolutely even leg length. And now let's check those flexors and extensors, because that's going to be critical, mostly if the patient has low back problems, to get this resolved. If you can't get the main flexors and extensors in the lower body to act properly, you're always going to have problems with the low back staying adjusted. So we're going to check the flexors. Resist, and they're back to normal there. Resist, back to normal there. Resist, okay. Resist, okay. So she's back to normal now. Now, is there anything I need to manually adjust? Probably. And there's an easy way to find out where the main interference in her nervous system is. Now that I have her balanced in a sensory setting, I want to check the motor system now. And so I'm just going to go back side of my right hand, which carries with it what? South pole. I'm back on the south part of the body. Think of the body being cut sagittally down the middle. Everything from the middle down is going to be south in a supine position. Everything from the middle up is going to be north. So I'm going to take my hand south, put it down at 5th lumbar. Resist. I know the main interference in her system today is not in the lumbar area. I'm going to go to 5th thoracic. Resist. Same thing. It tested strong. Her body is basically telling me where to go and what to adjust. I'm not the one in charge anymore. Her body is. Now I'm going to use a south pole finger. I'm going to go to C5. Contact the spinous process of C5 and resist. Uh-oh. We have a weakness. Now, did that tell us exactly where the problem is in the cervical spine? No. It just told us there's a problem in the cervical spine. Now, there's an easy way to find out exactly which vertebra is out of place. I already suspect it's Atlas. But, just for fun, we'll do it this way. I'll go to C7, south pole contact, and it's strong. C6, strong. C5, strong. C4, strong. C2, 3, strong. C2, strong. Atlas, weak. And just as I suspected, it's Atlas. Now, there's another way of doing this, and some of you doctors might be familiar with Van Rump technique. It's been around since the 30s or 40s. I can't remember if it was the 30s or 40s, but it's been around a long time. And basically how it works is you come down to the feet with the patient in a supine position, and you look at the feet when they're balanced, or as balanced as you can get them with a manual adjustment or whatever technique you use. And you just say, give me an absolute yes. And notice that this right leg went long. And then I said, give me an absolute no, and the legs went back to even. Now, who in the world am I talking to? Well, basically, I'm talking to their innate intelligence. Normally, when I do this, I'm not saying it out loud either. I'm just doing this to myself. But basically, I'm trying to communicate with her innate intelligence. I'm getting my innate intelligence in tune with hers. And I'm just looking at her body and saying, okay, body, what is it? Give me a yes. What would be a yes? Long leg. What would be a no? Even legs. We can also do that up here using the deltoid muscle. Give me an absolute yes. Strong. Give me an absolute no. Weak. Same thing. So the body is always communicating with us. We just have to know how to read the language or hear the language. And that's what we're doing. So I'm gonna go down to the legs. I'm gonna use Van Rump. Give me an absolute yes, absolute no. Now I have a totally different yes and no, by the way. It went from long leg to short leg now. Short leg is now no. I guess the body wanted to change for some reason. You'll find this quite often in female patients. That's a joke. Okay, now, so we have an absolute yes, an absolute no, and we know that the problem is at C1 at Atlas. Is that correct? We get a yes. Now, is it anterior superior? No. Is it anterior inferior? Yes. Anterior inferior. Is it left posterior? No. Is it right posterior? Yes. So we've got an anterior, inferior, right, and posterior atlas vertebra that needs to be adjusted. And I'm going to do that now using just standard Palmer technique, diversified for you doctors from other schools. And I'm going to test this again. Resist. Good. That's good and strong. Now I'm going to go back here. Give me an absolute yes, absolute no. Did that correct the problem? We got a yes. Is there anything else I need to do for this patient today? No. So, I'm finished. My work is done. And this patient is now clear of interference, both at the spinal level, at the area of major subluxation interference to the nervous system, and also she's now clear in these major cortical centers. So until the next time, this is Dr. Roberts saying, the only rational approach to health is maintenance. Stay adjusted.